Hi everyone, we are group 13 and we will be presenting a case study on valvular heart disease. Our patient, who we will be calling John for the purpose of this presentation, is a 49-year-old male who is presenting with dyspnea or shortness of breath with exertion, occasional chest pain with exercise, and a sense of pounding in his chest while running. He has a history of a mild heart murmur, but no other known comorbidities. John enjoys recreational running and is a healthy weight for his demographic. He was previously running 4 kilometers every morning and occasionally competed in half marathons. He now cannot run for more than 10 to 15 minutes without experiencing dyspnea. John has had a physical examination done, an ECG, and an echocardiogram. The physical examination by stethoscope revealed that he has a systolic and diastolic heart murmur, which may suggest pulmonic regurgitation, and a faint ejection click was heard at the apex. His ECG displayed left ventricular hypertrophy by voltage. His echo revealed normal systolic function, normal left ventricle ejection fraction, but moderate aortic regurgitation. It was determined that John was experiencing severe aortic stenosis, stenosis being the obstruction of forward flow, in a bicuspid aortic valve, as well as moderate aortic regurgitation. Only 2% of the population have a bicuspid aortic valve, but it is a common congenital heart condition. John is very active, and we can estimate that before experiencing the breathlessness, he was spending around 140 to 175 minutes per week of moderate to vigorous exercise in his running habits alone. We don't have enough information on his work or life habits or sedentary behavior. So we need to complete exercise testing to understand John's clinical severity, and we will be testing functional capacity through exercise echocardiography, symptom response, and exercise blood pressure. With the symptom response, we're looking for exertional symptoms such as dyspnea, chest discomfort, and palpitations. With the electrocardiography and blood pressure during exercise, we're looking for hypotension or a drop in blood pressure during exertion and reduced peak VO2. The contraindications here would be that aortic stenosis reduces the sensitivity and specificity of exercise testing. We also need to keep an eye on his RPE and ensure that it doesn't get too high for his condition. This is just a diagram to show where John is at in regards to the severity of his condition. And so because he has moderate aortic regurgitation, he could participate in all sport and exercise. But since he also has severe aortic stenosis, it's recommended that he stick to low-intensity sport and exercise only.
To give an overview of the exercise prescription for this case, in the absence of aortopathy, exercise recommendations for individuals with bicuspid aortic valve dysfunction are identical to individuals with tricuspid aortic valve dysfunction. And with regards to contact sports, studies show that athletes with bicuspid aortic valve dysfunction should avoid sports with strong isometric components, even with minimal valvular dysfunction. And lastly, valvular heart disease is a mechanical disorder, and definitive treatment requires surgery. We can prescribe exercises to improve quality of life for John or improve surgery outcomes for preoperative patients. Now moving on to exercise prescription with regards to aerobic exercise. According to literature, individuals with valvular heart disease should engage in low-intensity exercise 4 to 5 days per week, with a rating of perceived exertion of 13 or less. Individuals like John are recommended to start 10 to 15 minutes at a time and gradually increase 5 to 10 minutes per week. Implementing extended warm-up and cool-down periods of 10 to 15 minutes are important to prevent sudden blood pressure changes. And finally, walking, cycling, and seated aerobic exercise have shown to be the most effective forms of aerobic exercise. A systematic review conducted by Zhang and colleagues show that these exercises led to significant improvements in cardiopulmonary function and exercise capacity. These modalities also ensure activity can be performed safely within recommended intensity parameters. To develop our aerobic exercise program, we follow recommendations provided by Zhang and colleagues. In weeks 1 to 2, we start with seated cycling and slow-paced walking for 10 to 15 minutes. From there, weeks 3 to 4, treadmill walking with a slight incline and water aerobics for 15 to 20 minutes are incorporated. In weeks 5 to 6, we focus on brisk walking and water aerobics for 20 to 25 minutes. Week 7 to 8 focus on walking intervals and stationary cycling for 25 to 30 minutes, while weeks 9 to 10 include continuous walking and slow resistance elliptical training for 30 to 35 minutes. Studies have consistently shown that with every increase in metabolic equivalent, or the intensity of the physical activity, the risk of mortality reduces by 12% for individuals like John. The goal is to gradually build endurance while ensuring the exercises remain within safe intensity levels, which allows John to develop cardiovascular adaptations appropriately.
Now moving on to exercise prescription regarding resistance exercise. A study conducted by Sasaki and colleagues seek to identify risks of resistance training for those with severe aortic valve stenosis. Their findings concluded that exercise performed at a frequency of 3 times a week did not have any adverse effect on the patients. They used a low-intensity exercise training program known as BRET, which stands for Bodyweight Resistance Exercise Training. Within the study, the patients performed 2 sets of 8 repetitions with 1 to 2 minutes of rest in between exercises. These exercise sessions should be around 20 to 30 minutes. Low-intensity exercises should be included primarily while utilizing the core and lower body as to not aggravate any symptoms in the upper body. For our resisted exercise plan, we incorporated similar techniques from the Sasaki and colleagues study. Our program is a 10-week plan broken down into 5 different stages, primarily focusing on core and lower body exercises. The first week is very low intensity and low repetition. The main exercise that we prescribe is chair-assisted bodyweight squats and seated leg extensions. The patient should perform 2 sets of 4 repetitions of all their exercises within the session. Progressing to the next stage in weeks 3 to 4, the main exercises for this session change to sit-to-stand calf raises and seated leg lifts, with the same 2 sets of 4 repetitions. The next stage sees a slight increase in sets from 2 to 3, but with repetitions staying the same at 4. The exercises within this stage include unassisted sit-to-stand and step-toe taps, among others. In the penultimate stage, the sets stay the same as the previous stage, but the reps increase from 4 to 6. The exercise for this stage are similar, with patients performing unassisted sit-to-stands, step-ups, and assisted lunges, among others. The last stage should see the same sets of 3 and 6 rep intervals, but the exercises will become more difficult with step-ups with higher steps, seated oblique twists, overhead shoulder presses using resistance bands, and resistance band bicep curls. Only in the final stage is upper body exercise prescribed, but in extremely low intensity. The last stage of exercise prescription is flexibility. Tai Chi has been shown to improve quality of life, mood, and exercise self-efficiency. It can help improve balance and weight shifting, breathing techniques, and internal awareness. This is a good option for John as it is low intensity and incorporates balance and flexibility training. Additionally, yoga is a great low-intensity option in improving balance and flexibility, and in cardiovascular disease. It can stimulate the vagus nerve and promote a healthy parasympathetic to sympathetic nervous system ratio. It can reduce perceived stress through a mindfulness meditative stance that strengthens selective attention on exercise and musculoskeletal stretching. It can also reduce the inflammatory response. It may be a contradiction depending on how long you are holding positions for, though, as we want to eliminate isosymmetric contractions. And we also want to ensure that the patient is not holding their breath.
So overall, we have created a low-intensity exercise plan because the literature shows that those with severe aortic stenosis should be limited to low-intensity activity, and with moderate regurgitation, we should avoid high-static exercises. Some sources suggest to encourage gentle walking or cycling for 20 to 30 minutes 5 times per week, and also recommend 3 to 6 repetitions, while the ACSM text suggests building to a maximum of 8 repetitions. We chose to work with resistance bands over weights, as heavy weights may induce symptoms in patients with severely stenotic lesions, and it is suggested to consider increasing the number of repetitions and sets prior to increasing weights. Our plan differs from the ACSM guideline as it includes special considerations for severe aortic stenosis and we provide a clear 10-week plan for John while the ACSM just provides a very general guideline. We would like to know more about John's activities of daily living, work, and home habits to help us get a more comprehensive understanding of his sedentary behaviors and how he is being affected by his condition. There are many gaps in the research regarding an exercise prescription outline specifically for those with bicuspid aortic valve disease and severe aortic stenosis. We would like to see more research on exercise effects for these populations.